So, trauma-induced coagulopathy, by definition, is a complex coagulation disorder that occurs after severe trauma. Okay, it is categorized by dysregulated clot formation and breakdown. Okay, so it is similar to what happens in burns, right? It's a dysregulated response to an event. Okay, in burns it was inflammatory response. Okay, here we are seeing a problem with the coagulation pathway. So what happens in trauma-induced coagulopathy? It can be either a hypocoagulable disorder or a hypercoagulable disorder. Okay, so that is the definition of trauma-induced coagulopathy. Okay, major trauma causing complex coagulative disorder characterized by dysregulated clot formation and breakdown. It can be either hypo or hypercoagulable state. Coming to pathophysiology, what is the major issue here? The first and foremost is the trigger, that is your primary drivers. Tissue injury, as soon as there is a major trauma, there's a outburst of tissue factor release. Okay, that triggers the coagulation cascade, that is your extrinsic pathway. Okay, along with this there will be some amount of hypovolemia, acidosis, hypothermia. All of along with your resuscitative effort causes some amount of shock and hypoperfusion to the organs. Along with this, there will be, if things are not kept in check, this will lead to endothelial injury because of disruption of the endothelial barrier, leading to abnormal activation of platelets and coagulation pathway. So, what are the major mechanisms by which TIC or trauma-induced coagulopathy happens? It can be hyperfibrinolysis. Okay, that is excessive tissue plasminogen activator presence, which breaks down the fibrin clots. Usually, a clot has to form and prevent bleeding, but because excessive presence of TPA, this clot breaks down and patient ends up bleeding again. So that is one, that is hyperfibrinolysis. The second one is platelets are present but they are dysfunctional. Okay, sometimes the number can be normal, or some on the other hand it can be reduced as well. Okay, so this is one more reason why there can be trauma induced coagulopathy. Majorly when we are talking about platelets in trauma, it can be dilutional thrombocytopenia. That is usually in the second half phase when you have resuscitated the patient with some amount of resuscitative fluids. It can be your crystalloids, blood, or a combination of both. The other mechanism is coagulation factor depletion. Okay, it leads to a DIC like state. Along with this, there will be an inflammation thrombosis crosstalk. Okay, there will be complement activation and inflammatory pathway which gets exacerbated, and that is one reason where you will see a hyperfibrinolytic pathway. Okay, I told you it can be both bleeding type, clotting type, right? So sometimes because of this crosstalk, what happens? There will be a clotting type of trauma-induced coagulopathy which can also be present. If we don't check all of this, the patient can end up in the lethal triad of death, which is characterized by hypothermia, acidosis, and coagulopathy. Okay, so remember this part. Okay, this is basically about pathophysiology of trauma-induced coagulopathy. I'll put in another slide which will help you understand. Okay, this, if they ask you about this, start about major trauma. There'll be three major problems. Okay, one is the shock, bleeding, tissue damage. Okay, tissue damage causes endothelial activation, neurohumoral activation. Both of this ends up causing platelet dysfunction and hyperfibrinolysis. Bleeding, what does it cause? It causes consumption of clotting factors. It causes hypocoagulation. Shock, what happens? We start resuscitating the patient, and because of shock, there is acidosis also. And once we start resuscitation, there will be hypothermia also. Okay, all of this will also worsen the clotting factors, which causes dilutional thrombocytopenia, dilution of clotting factors. All of this will end up causing hypocoagulation again. So because of these three major in initial triggers, there will be hypocoagulation, platelet dysfunction, hyperfibrinolysin, which causes trauma-induced coagulopathy. Okay, so if you can remember this: shock, bleeding, tissue damage causing hypocoagulation, platelet dysfunction, and hyperfibrinolysis, that causes trauma-induced coagulopathy. So if you write this much in exam, it's more than enough. Okay. So what are the stages? Okay, so initially you will see acute traumatic coagulopathy. Okay, followed by your resuscitative effects causing dilution of clotting factors, metabolic acidosis, interstitial edema, and hypothermia. And later on, you will see issues like trauma induced coagulopathy. Okay, so that is what usually happens. Along with this, what are the factors which worsen TIC? Elderly patients, male predilection is there, patients with pre existing issues requiring oral anticoagulation, patients with traumatic brain injury. All of these patients, along with some amount of genetic predisposition, they are known to develop trauma induced coagulopathy. Okay, so these are the stages of TIC. Okay, so if they ask you stages, you can write that, and you can also write telling that it is categorized as early TIC and late TIC. Early TIC is usually less than 6 hours. Okay, so it is usually of the bleeding variant. The late TIC is usually between 6 to 24 hours. It is a clotting type. Okay, so if you can see here, the tag also is given there for you to understand it better. Okay, what usually happens in the early TIC is hyperfibrinolytic pathway. Okay, clot is forming, but it is unable to sustain. Okay, there's an increased TPA presence. So at this stage in early TIC, there comes a role for tranexamic acid. Okay, so if you see the ATLS guidelines and TBI guidelines, and if you see about the role of tranexamic acid, they always say it is best given or best beneficial if it is given less than 3 hours. Correct? So this helps us understand, it correlates, right? So this is about early TIC. Late TIC is usually the clotting type. Okay, there'll be a coagulopathy because of the crosstalk that I was talking about earlier, inflammation, thrombosis, crosstalk, which happens. So in this particular patient, we need to look at the TEG, reassess, look for microthrombi, look at organ perfusion issues like acute kidney injury, encephalopathy, okay, all of this, and treat it accordingly. So this is about early TIC and late TIC. Coming to the effects of hypothermia and clotting. Till now, we were talking only about resuscitative effects, tissue factors, shock, bleeding, etc. But we told lethal triad of death usually has two other important things, one of which is hypothermia, correct? What does hypothermia do for clotting? So, whenever there is a bleeding which happens, the coagulation cascade is activated. And this cascade of enzymes are temperature sensitive. Usually, they're best in action when they are working at a temperature of 37 degrees Celsius. Okay. If there is hypothermia, okay, say it drops to less than 36 degrees Celsius, it's between 33 to 36. That is a moderate hypothermia. 50% of your enzymatic activity will be lost. If it drops below 30%, there will be bleeding type of a coagulopathy, which can be seen. It is majorly because enzymes are not working. Okay, so one of the drawbacks of TEG is this. If you feel that the TEG is normal but the patient is still bleeding, please look at the temperature of the patient. Okay, one of the drawbacks is TEG always normalizes the temperature, then check the enzymes activity. Okay, here, whenever you are having a bleeder present, look at this as well. Okay, because temperature also adds to the enzymatic machinery's functionality. Okay, factor 7A, which is the earliest factor to get depleted, or the factor which has the shortest half life, is the most vulnerable one. Okay, and it is highly temperature sensitive. If this is not present, the rest of the clotting cascade would not work properly. Okay, so this is the role of hypothermia on clotting. Coming to platelet function, what happens? Similar to what we see in enzyme machinery, whenever there is hypothermia, adhesion of platelets, production of thromboxane, okay, and the aggregation of platelet, all of this would be reduced. Okay, what happens in hypothermia is the possibility of this getting delivered to the liver and the spleen for sequestration becomes higher. Okay, so this is one thing that we need to remember about the effects of hypothermia on the clotting mechanism. What happens to fibrinolysis? Okay, in fibrinolysis, again, plasmin activity is not very much affected. Okay, so majorly clot breakdown does not happen. The clot itself is not formed. That is what is the major issue. But on the same time, okay, if the temperature is too low, if the clotting factors, the quality is not good, that itself can cause a breakdown, and that can result in fibrinolysis. Okay, so if someone asks you a question on what are the effects of hypothermia on clotting, answer them on three headings. Okay, so any clotting, you have to talk about clotting factors first, that is your temperature dependent enzymatic kinetics. Next, after clotting factors, you have to talk about platelet function, correct? So first clotting factors, platelets, then the final clot which is formed, that is your fibrin. So you talk in these headings. Okay, so temperature, platelet function, and fibrinolysis. Okay, so remember, major effects is on clotting factors and platelets. Okay, coming to the effect of acidosis, so this is the other triads part, right? So what they say is, once the acidosis worsens, okay, the best coagulation can be achieved in normal pH between 7.35 to 4.5. If it goes below 7.2, your factor, especially again your factor 7a, drops, the activity drops. Okay, and the generation of factor 10a and thrombin is also hampered. Okay, so what happens if the pH drops to less than 7? The factor 7a activity is reduced majorly by up to 90%. Okay, so fibrinogen is also impaired, the cross-linking does not happen, the clot is not stable, and this might cause the breakdown of the clot. Okay, platelet function is also altered, and it can cause degranulation of platelets, and the aggregation of platelets also do not happen in severe metabolic acidosis. Okay, so this is about the effect of acidosis on clotting. Coming to diagnostic approach for trauma-induced coagulopathy, okay, routine blood tests like your CBC, etc., have to be done. Okay, uh, look at the sites for bleeding. Okay, after that, arrest it. If there is any major visible bleed, probably you have to address it with your crystalloids. Then go ahead with blood products. Okay, you have probably, if the patient is in shock, your ABC score is high, probably activate your MTP. Along with the same time, do your laboratory test, do your PTA PTT INR, check your fibrinogen level. Okay, if you have a tech, go ahead and use it. Okay, having said that, you have to also remember the drawbacks of tech. Okay, so all of this would be the initial diagnostic approach for uh, this thing. What is that? Trauma-induced coagulopathy. Along with this, dyselectrolytemia has to be kept in mind, because you're giving products to this patient, so the patient can end up in hyperkalemia. And because you're giving a lot of products, there might be chelation of calcium that can lead to hypocalcemia. Okay, so keep check on calcium and potassium for these patients. Okay, so you have done your routine tests, you have got your studies. Okay, so how will you treat is what is based on the next step. Okay, that is your management. So next question is, if TEG is present, ROTEM is present, is it anyway superior to your coagulation testing? As of now, IACTIC study did not show that is superior over the other. Major thing is turnaround time. Okay, so if you have a TEG and ROTEM present there, it is a point of care device, so it will give you the result as early as possible. Okay, that is the major thing. Okay, but majorly no difference if you have ROTEM or TEG as compared to your hemogram. Just keep a watch and keep a follow up. That should be more than enough. Okay, so management, control bleeding, restore perfusion, uh, damage control resuscitation. I'll be talking to you in the next topic. Okay, so in that, you can do something called as permissive hypertension after ruling out 3BI. Okay, if 3BI is there, we can't do this. Again, you have to be very judicial in using crystalloids. Probably you might have to follow a massive transfusion protocol, and based on your proper trial, there is a ratio of 1:1:1. That is your plasma platelet and RBC bags. And based on your laboratory value of fibrinogen, etc., you might have to supplement this patient either on cryoprecipitate or a fresh frozen plasma. Always try and maintain the ionized calcium level of more than 1 millimole per liter. I told you early TIC, there is a big role for tranexamic acid, especially within 3 hours. Okay, the dosing is 1 gram over 10 minutes, followed by 1 gram IV over 8 hours. Okay, all along with all of this, avoid acidosis, prevent hypothermia. Okay, so if you have done all of this, if the patient is still bleeding, then you can think about the use of recombinant factor 7a, desmopressin, etc. Okay, this is again management of bleeding. Okay, in general, whatever you do. Okay, so when do we think about the need for recombinant factor 7? When the pH is normalized, you have got it at least more than 7.2, you have normalize the ionized calcium of more than 1.1 millimoles per liter. Temperature is normalized, fibrinogen is normalized, platelet count is optimized. If you have done all of this optimization, then think for the factor 7. Otherwise, if you have not optimized all of this, don't routinely ask factor 7. Okay, these are the checkpoints for the indications for use of recombinant factor 7. Okay, so targets in TIC, systolic blood pressure, non-TBI 80 to 90, in TBI more than or equal to 110, MAP targets roughly 60 to 65, maintain temperature, pH, reduce the base deficit. Base deficit you can't directly look into, but what is the target is between 0 to -2. Fibrinogen, maintain it more than 1.2 grams per liter or 1.5, it's the best way. Try and optimize the platelet count up to 1 lakh. Okay, and the hemoglobin target, if it's more than 7 grams, it's more than enough. Again, depends on the comorbidities associated. Okay, ionized calcium should be more than equal to 1 millimole per liter. Okay, this is about the diagnosis and management of trauma induced coagulopathy. Okay, thank you. Any questions in this? So coming to the next topic, that is about damage control resuscitation. Okay, so is my slide visible? So damage control resuscitation is a systematic approach used to manage severely injured patients, particularly those with life-threatening hemorrhage, to optimize survival by addressing the lethal triad of trauma, that is your hypothermia, acidosis, and coagulopathy. This concept is rooted in minimizing further physiological deterioration, wherein we stabilize the patient for a definitive type of care. Okay, it's like buying time. Okay, so that is the whole understanding of DCR. Okay, you're looking at addressing the most life threatening hemorrhage at the earliest, try to prevent the lethal triad of death, stabilize the vitals, and then take the patient for a definitive care. Okay, so it's a stepwise approach. So, what does DCR encompass? It has permissive hypotension, minimizing the use of crystalloids, a protocolized transfusion, and hemostatic resuscitation. Okay, this is what we look in damage control resuscitation. So, remember in pathophysiology, what usually happens in DCR is there will be first hit and second hit. Okay, the first hit is the SIRS, which is usually because of the serious injury which happens. Okay, injury, that is trauma, causes SIRS, that causes activation of the immune inflammatory system. The second hit is what we are worried about. Okay, the second hit can be iatrogenic. Okay, when does that happen? It is because of uncontrolled physiological disequilibrium. Okay, that can be because of our IV fluids, it can be because of hypothermia, etc. Okay, or else sometimes it can be a sequelae of the primary insult itself. Okay, so these two things can push the patient into trauma induced coagulopathy or can push the patient into lethal triad of death. Okay, that has higher mortality. So this is basically the underlining need for damage control resuscitation. So the next question will be in when and in whom we initiate DCR. Okay, so in patients with major trauma, okay, firstly we need to look at patients whether they have major trauma. You've analyzed whether the patient is in a red zone, yellow, or green zone. Then you triage this patient and transport this patient. Firstly, you do a damage control resuscitation or a damage control surgery, then optimize the hemodynamics. Hemostatic resuscitation would be done. Then you plan and do a definite surgery. Okay, so this is where we do. Okay, lastly, we have the reconstructive surgery. These are the phases of DCR. Okay, so coming to damage control approach, it can be anatomical injury or it can be a physiological derangement. Okay, so the question I asked you earlier, where and in whom? Okay, I'm sorry, the earlier slide came in as a googly. Okay, it was the phases of DCR which you saw. Okay, starting from triaging, DCR, okay, hemostatic resuscitation, definitive, and rehabilitation. Okay, and coming to the question of whom to do it, you have to look at two things. Okay, one is the anatomical parameters, another one is physiological parameters. If you cannot remember this, I have another slide where you can remember it in total. Okay, patients with an injury severity score of more than 36 warrant DCR. Patients with penetrating abdominal or chest injuries warrant DCR. Unstable pelvic fractures, long bone fractures, head injury, truncal hemorrhage, or amputation. All of these patients would require damage control resuscitation. Patients with physiological derangement, okay, especially leading to excessive tachycardia, absent radial pulse, with any other type of injury, also might require damage control resuscitation. So, what I talk about physiological parameters are patients who do not have the above anatomical derangements but still have signs of hemodynamic instability. In those patients, also, you can initiate DCR. Okay, so none of these criteria should be used as an isolation. It should be on a case by case scenario, and most of this you can remember looking at the clinical presentation of the patient. So, what is the changing paradigm in management of a patient with trauma and DCR? Here, the ABC becomes CABC. Okay, that is the most important thing is you have to address the catastrophic hemorrhage which is happening to the patient, because in the meanwhile you're doing all the other resuscitative effects but you have not addressed the leaking patient. Okay, so if you have not plugged the hole there, probably this patient will bleed out and exsanguinate to death. Okay, so that's the reason they say if there is a compressible hemorrhage, especially from an extremity, that would rapidly kill the patient, start with addressing that along with your ABC approach. Okay, so it should happen in a simultaneous process. So it is a team based approach, and in team based approach, start with the catastrophic hemorrhage in tandem with your ABC. So that is a part of damage control resuscitation. Okay, so how do we do that? You can use field dressing, tourniquets, hemostatic agents, sometimes even riboa. Okay, so these are the things that you can do to avoid a catastrophic hemorrhage. Okay, so coming to the role of radiology in this, so what do we do? Firstly, we do an e-fast, and if we are unable to find out any bleeder, probably we can even think of doing a CT angiogram or a polytrauma CT. Okay, but all of this depends on the hemodynamic stability of the patient, and if we feel that there is active bleeder anywhere, probably you can even in the same setting do an angioembolization of the bleeder as well to arrest the bleeding. Okay, so the role of radiology in damage control resuscitation can be of two things. It can be diagnostic or therapeutic. Okay, so firstly we start it as a diagnostic tool with the efast. Okay, so if at all the patient's hemodynamics is stable, then we can go ahead with the definitive tool like a CT angiogram followed by an angioembolization plus or minus depending on an active leak. Okay, this is the role of radiology in damage control resuscitation. So I told you earlier there were the five phases which we discussed. The initial surgery in a DCR is always a life-saving procedure. Okay, so usually it should be less than 90 minutes. Okay, the OT time should not be very high. You just have to control the hemorrhage, prevent contamination, make sure the patient gets a very judicial fluid resuscitation, and the patient is shifted back to the trauma unit for further observation and management. Okay, it's just a temporary surgery. The second phase is the ICU resuscitation phase, wherein we have to optimize the hemodynamic targets. So avoid your lethal, prevent your lethal triad of death or your diamond of death, that is your hypocalcemia as well. Okay, so all of this have to be kept in mind. Optimize end organ perfusion, prevent acute kidney injury, ventilate the patient if required. Okay, all of this has to be addressed in phase two. Definitive surgery is usually after we have stabilized the hemodynamics. It can be anywhere between 24 to 48 hours period. Okay, so permissive hypotension is a part of damage control resuscitation, especially in the first 6 to 12 hours period. What do we do this? Usually we maintain a lesser systolic blood pressure target. All of these patients who have trauma do not warrant permissive hypertension. I'll be talking to you about the limitations for the use of permissive hypertension. Why do we do this? Firstly, it is to limit the blood loss. Along with that, they also say that a clot which is formed, if at all there is a fluctuation in blood pressure which happens in these patients, can cause dislodgement of cause clot and further bleeding. So this is major reason why they think that permissive hypotension is the best way forward in damage control resuscitation in the early phase. Okay, so what is the target blood pressure? You target the target, a BP between 80 to 90 millimeters of mercury in patients without traumatic brain injury. Okay, if it's TBI, probably you have to have a higher target, that is 110 millimeters of mercury. Okay, why higher? It's very straightforward. You have to maintain the cerebral perfusion pressure. Okay, so what are the challenges associated with permissive hypotension? Always you're compromising vital organ perfusion. Watch for oliguria, anuria, AKI, shooting up of liver enzymes. Okay, probably you can't feed the patient, obviously. And if it is a gut injury, again, a lot of issues related to gut translocation of bacteria. All of this is possible. Okay, these are the challenges associated with permissive hypertension. The other thing is patients with elderly age group, chronic comorbidities, which is uncontrolled, especially IHD, CKD, they may not tolerate this, permissive hypertension, and that can further worsen their organ failure. And as you all know, in TBI, it's a contraindication. After permissive hypertension, the next important thing is balanced fluid resuscitation. That is the component of damage control resuscitation. What do we do this? Avoid excessive fluid overload in these patients. Okay, have a close watch. Okay, a goal directed therapy with your hemodynamic parameters is necessary. After 1 liter of crystalloid therapy in trauma, better to use your blood products. Okay, so things like your ABC score, shock index, etc., would be a trigger factor. Okay, or else you can also use your ATLS hemorrhagic shock algorithm for initiation of your MTP protocols. Okay, so remember, this is a patient who is sick, this is a patient who is bleeding, this is a patient who is going to have multi-organ failure. Okay, so you need to prevent adverse effects of your resuscitation. That is what is the goal of balanced fluid resuscitation. Okay, in the meanwhile, with permissive hypertension, you have to maintain the intravascular volume. Okay, optimize coagulation factors, check in for derangements like hypothermia, hypo uh, hyperkalemia, hypocalcemia, and metabolic acidosis. Okay, all of these are metabolic derangements associated with fluid therapy and damage control resuscitation. Okay, so dilutional coagulopathy is the major problem along with hypothermia, which we see with excessive fluids. Okay, and along with this, you should have a proper ratio, that is 1:1:1, based on your proper trial and prompt trial. Okay, so that is one thing. Early use of blood products, that is the best way forward in DCR. Okay, calcium replacement is similar to what I discussed with trauma induced coagulopathy. Okay, I told you earlier as well when we were discussing about fluid resuscitation, especially in burns. Okay, similar to that is what happens here as well. Okay, excessive fluid can lead to compartment syndrome, initially abdomen, or it can be a polycompartment syndrome. Okay, so targets is similar to what we saw earlier on. Okay, so you need to maintain a map more than 60 to 65, urine output of more than 0.5 to 1 ml. Calcium should be more than 1, prevent coagulopathy. Okay, and try and normalize the lactate. Okay, these are the targets which we usually see with balanced resuscitation or damage control resuscitation. uh, Crash 2 proper trial is for your blood products. Crash 2 evidence is for a tranexamic acid, early tranexamic acid. Okay, all of this can also reduce the use of blood products, right? So that is how it is. And coming to per se, what is the evidence for damage control resuscitation? There's one trial called as by Mattox et al. In 2017. Okay, so in which they looked at patients with military wounds. Okay, they said early balanced resuscitation and rapid hemorrhage control had better outcomes. So this is majorly where we have the data from. Okay, that is your military backgrounds. Okay, that's about your damage control resuscitation. Okay, thank you. So you can write the same targets which I mentioned in trauma-induced coagulopathy for damage control resuscitation. Okay. Any questions? Okay. I don't see. I'm coming to the last talk for today. Okay. About trauma and toxicology. I'll be joining back again for pregnancy-related topics. Okay. So the last topic would be massive transfusion protocol and hemorrhagic shock. Okay. So Hemorrhagic shock is a life-threatening condition resulting from significant blood loss, leading to inadequate tissue perfusion and oxygenation. Okay, so it is characterized by hypovolemia, reduced cardiac output, and cellular hypoxia, leading to impaired organ function, potentially leading to death. Okay, if not checked at the right time. So if you remember this heading, it's more than enough. So what are the key features? Usually in hemorrhagic shock, there is hypovolemia, that is because of decreased circulating volume, which causes hypotension. Okay, and that will in turn cause tissue hypoxia. Okay, tissue hypoxia in turn can lead to metabolic acidosis. So, what is the primary cause? It can be trauma, surgery, gastrointestinal, obstetric cause, etc. So these are the causes. Okay, and what is the physiological response to bleeding or hemorrhagic shock? There will always be a compensatory response. No, so it will be increased heart rate, vasoconstriction, and activation of the renin-angiotensin aldosterone pathway. So this is majorly what you need to write about hemorrhagic shock. If someone asks you definition, causes, physiological response, and pathophysiological effects or sequelae of hemorrhagic shock. Okay, if you can take a screenshot of this, it's good enough. Okay. So classification is the next important thing in hemorrhagic shock. It is classified into four classes. Okay, so it's class 1 mild, that is blood loss less than 15% of the total body volume, that is around 750 ml in a 70 kg adult. In class 2, it is moderate hemorrhagic shock between 15 to 30% loss, 750 to 1500 ml of blood loss. Okay, here you will see tachycardia, decreased pulse pressure, anxiety, etc. Okay, so altered mental status happens in second grade or class 2 shock. In class 3, it is a severe type of a hemorrhagic shock. It is blood loss of 30 to 40% with roughly up to 2 liters of blood loss. Patient can have signs of end organ hyperperfusion like oliguria and altered mental status. Class 4 is a life-threatening shock wherein the blood loss is usually more than 40% and the total blood volume loss would be more than 2 to 2.5 liters. And this patient will be in a state of altered mental status, distress, and will be in a stage of doom, that is impending cardiac arrest. Okay, so that is what we see in class 4. Okay, so what are the clinical hallmarks of hemorrhagic shock? Systolic BP of less than 90 mm of Hg in severe cases, tachycardia, narrow pulse pressure. Along with this, signs, what do we see? Cold, clammy extremities, prolonged capillary refill time, oliguria, and altered mental status. In metabolic pathways, what do we see? An elevated lactate of more than 2 millimoles per liter and a base deficit, which we elevated, okay, more than minus 2 millimoles per liter. Okay, that is what we see in ABG. So this is the same classification that I have mentioned earlier. So what you have to categorize them is class 1, 2, 3, and 4. Percentage of blood loss, what happens to heart rate, BP, pulse pressure, GCS. Okay. Remember, grade 3 shock, you have to activate the alert the blood bank that the patient might read. And once the patient goes into class 4 hemorrhagic shock, you need to activate MTP. So this is one thing I wanted you to take home from this slide. Okay. So recently in Journal of Clinical Medicine, no, they have had another staging of hemorrhagic shock. I wanted you to look into this as well. Okay, wherein they have categorized hemorrhagic shock into 5 stages. Okay, so it is basically, imagine the patient has come to your ER or your ICU. Okay, and the patient has developed hemorrhagic shock. How the patient progresses and what happens in each stage is what they have told this as. So initially, when the blood loss is very minimal, less than 10%, it is stage 1. Okay. So only skin signs and tachycardia will be present. That is called as a stable hemorrhagic shock. The next thing is called as stabilized or compensated hemorrhagic shock. That is stage 2, wherein the patient is responsive. Okay. So if you have read your ATLS guidelines, there is one particular terminology where they use as responders, fluid responders and non-responders. So this is basically based on this categorization. Okay, so if at all your patient has hemorrhagic shock, they respond to fluid resuscitation, they fall under stage 2 shock, that is stabilized compensated hemorrhagic shock. If your patient is transiently responding to fluids and blood blood products, then he is categorized in stage 3, that is your progressive unstable hemorrhagic shock. Who are these patients? They have hypotension and they have transient response, usually between 30 minutes or less. Okay, and even after giving 2 or 3 boluses of 500 ml of crystalloid, they go back into shock. Okay, so such patients who improve and go back are patients called as progressive unstable hemorrhagic shock. Stage 4 is critical hemorrhagic shock, wherein there is impending cardiac arrest, similar to what we saw in the ATLS categorization. Okay, so wherein there is shock with end organ hyperperfusion signs, usually categorized by a blood loss of more than 40%. And the last thing is a patient who is categorized with patient with cardiac arrest. So that was the limitation of the previous thing, if you look into it also. Okay, so they are not categorized what happens if the patient has a cardiac arrest due to exsanguination. So this actually includes those patients. So cardiac arrest by exsanguination is categorized as stage 5. So this is just to, have a comparison. This is the American College of Surgeons and Trauma, the same thing which we spoke about earlier, as compared to the new guidelines based on staging. Okay, so coming to the next important part of management. Okay, again, hemorrhagic shock, we know initially you need to manage with crystalloids followed by blood. If this doesn't happen, if the patient slips into stage 3 and stage 4 he ends up, then you have to activate the MTP protocol. Okay, so that is where we come into the discussion of MTP. Okay, MTP, there is no single universally accepted definition. Massive transfusion protocol is a standardized systemic approach to the rapid and efficient replacement of blood and blood products in patients with life-threatening hemorrhage. Okay, it is designed to optimize hemostasis, restore circulating blood volume, and prevent complications associated with massive transfusion. Massive transfusion is different. Massive transfusion protocol is different. Okay, remember, if they ask you what is MTP, tell it's a standardized systemic approach with rapid efficient replacement of blood and blood products given to treat patients with life-threatening hemorrhage. On the contrary, massive transfusion is these. Okay, patients who have replaced more than 10 who have required more than or equal to 10 units of PRBCs within 24 hours, or patients requiring more than equal to 4 units of PRBCs within 1 hour, or replacement of more than 50% of the total blood volume within 3 hours, categorized as massive transfusion. Okay, so what is the goal of MTP? It's rapid delivery of blood products in a systematic fashion and to minimize complications, especially the lethal triad of death, that is coagulopathy, acidosis, and hypothermia. Okay, this is the goal of MTP. Okay, so remember, if they ask you lethal triad, this one, diamond of death include hypocalcemia. Okay, so this is about the focus or the need for MTP. Why MTP? Okay, so because it's a very structured format, it has a clear criteria which activates the MTP protocol. You have a predefined blood product ratio. The protocols for monitoring, adjusting the therapy based on clinical and laboratory data. You are reassessing. Okay, so these are the 3 reasons why MTP is necessary. Okay, so it is a structured approach with clear guidelines for activation and stoppage, and you get blood products in a fixed ratio. So that is one of the major advantages of MTP. So what are the tools for activation? I told you earlier, there are multiple tools that you can use. Remember one of them. Okay, one is critical administration threshold. Whenever your patient has hemorrhagic shock, if they require more than 3 PRBCs in 1 hour, you can call for MTP. Shock index is one thing, that is heart rate over systolic blood pressure. If it is more than 1, even then you can activate an MTP. If an ABC score is present of more than or equal to 2, then you can activate MTP. What is ABC score? It is nothing but patient with penetrating mechanism of trauma, systolic blood pressure of less than 90 mm of Hg, heart rate of more than 120 beats per minute, and a fast positive ultrasound. So if these are present, then the patient is categorized as a patient who requires MTP. There's another tool called as a RABT score. Okay, RABT is slightly a little more sensitive and specific as compared to ABC score. Okay, along with this, what it does here is systolic blood pressure and heart rate, it combines it into a shock index. Okay, so other things are similar. There is fast positive, there is shock index, penetrating mechanism. Only other additional thing that we could do is pelvic fractures. Okay, pelvic fractures are notorious to cause concealed hemorrhages. Okay, so concealed hemorrhage is one thing which can be easily missed. Okay, especially when you're doing a fast as well. Okay, so in such cases, that is the reason it is mentioned as a separate entity in RABT. Okay, so what are the seven T's of trauma resuscitation? You should have a trigger plan. It's a team-based approach. Early use of tranexamic acid, test hourly, achieve the target, prevent hypothermia, and terminate the code when stabilization has occurred. What are the steps? It's 6 steps. Okay, so you identify based on your scoring systems. Okay, you have a clinical judgment, activate it, talk to your transfusion officer or a blood bank. Then step three, and you will check for your clotting parameters. You send a CBC, everything. Okay, LFT is supposed to be done. Your fibrinogen value has to be done. Okay, and coagulation parameters. You give tranexamic acid, like I've mentioned earlier, 1 gram 10 minutes, less than 3 hours, 1 gram over 8 hours. Okay, then we need to get blood products in a fixed ratio. 1:1:1 is what is uh, good enough instead of 1:1:2. Okay, so this again 1:1:1. It does not mean one bag of plasma, one bag of SDP, or one bag of RDP, and one bag of PRBC. It depends on the local institutional protocol. Okay, it can be one bag, it can be 3 bags, it can be 6 bags. The ratio is what is mentioned. It is not the number of bags. Okay, please keep that in mind. Okay, so it can include FFP or cryoprecipitate. It is depending on the availability. Okay, after this, after you have done a fixed ratio resuscitation once, you have to check, okay, whether hemodynamic stability has occurred firstly, whether clotting parameters have normalized. In this place, probably you can use TEG and ROTEM if it comes earlier. If you don't have, then you can send a CBC, PTINR, okay, and then check for dyselectrolytemias, etc. Monitor for hypokalemia, hypercalcemia, correct them if at all it's present. The penultimate step is, once you have achieved a goal, okay, your fibrinogen value is more than 1.2 grams per liter, ionic calcium is good, more than 1 millimoles, okay, and your INR is normalizing, you have a platelet count which is in an improving trend, and hemodynamically the patient is stable, then you can stop the MTP. Okay, so this is the 7 steps for MTP. Okay, so activation. Okay, first identification, activation, assessment of coagulopathy and adjunctive therapies, transfusion of products, reassessment after delivery. Then, once reassessment is done, once the targets are achieved, stoppage of MTP. Okay, this is about MTP. What are the guidelines for calcium replacement? I told you earlier, each unit of PRBC or FFP contains citrate that becomes the chelator, which binds to the calcium and reduces bioavailability. Okay, severe hypocalcemia can itself be the cause for bleeding. Okay, so that is one thing you have to remember. So what they say is, for every 4 to 6 units of blood products transfused, probably you might have to check the ionized calcium and then give the patient ionized calcium. So there are many ways that we can give calcium, either by calcium gluconate or calcium chloride. Remember, when you're giving calcium chloride, it is for a central venous access because it's too painful. Okay, so that is the reason calcium chloride is usually not routinely available. Calcium gluconate is a good enough option. Okay, so the only advantage of calcium gluconate is it can be given in the peripheral IV access. Okay, dose is 1 to 2 grams for calcium gluconate, and chloride it is 0.5 to 1 gram IV. Okay, so what are the triggers again for checking this? If you have, one is the blood bag, two, ionic calcium. Okay, three is if you're having ECG changes. All of this are triggers for giving the patient IV calcium. Okay, so along with this, if there is ongoing bleeding also, you can think about and supplement it. Okay, so always don't stop monitoring calcium as soon as MTP is stopped. Post MTP also, there may be some amount of utilization over a period of 6 to 8 hours. So recheck calcium another 12 hours later as well. Okay, so this is an example for one of the hospital based activation coding. Okay, so as you can see, there is initial management, specific things, they have involved cell salvage. Okay, they've pre-specified the dosages. Okay, what they said is one adult therapeutic dose, especially if the platelet count is less than 50,000 for platelets. Okay, so adult therapeutic dose can either be 4 to 5 bags of RDPs or 1 bag of STP. In INR, they've told 15 ml per kg of FFPs. If it is cryo, they have told 3 to 4 grams of cryoprecipitate. Okay, so this is a very clear, very good guideline. It is different from different hospitals. Okay, so this is one such examples that I have put here. Okay, recombinant factor 7, I told you earlier also. Okay, always make sure no acidosis, no hypothermia, blood products are normal, platelets are normal, and your clotting factors are okay. Only then lastly you give recombinant 7. Otherwise routinely don't use recombinant factor 7. Tranexamic acid, there are a lot of trials. They have told you earlier in trauma-induced coagulopathy less than 6 hours, you saw, right? There'll be hyperfibrinolysis. So that's the place where the role of tranexamic acid has been proven beyond any doubt. Okay, so I don't want to repeat again. Loading dose is 1 gram over 10 minutes. Maintenance dose is 1 gram IV infusion over 8 hours for 24 hours based on your crash trial. Okay, crash 2. So evidence for tranexamic acid, please remember MATRIS trial, crash 2 trial. Okay, these are most important. Again, you have crash 2, crash 3 both. Okay, so it is TBI, trauma, both come into picture. Okay, both places tranexamic acid has proven some benefit for sure. Okay, so both this is the evidence for the use of tranexamic acid. What majorly all of these trials are telling, early initiation. Early initiation, what is the timeline cutoff? 3 hours. Okay, so what do you do in MTP? You have to monitor temperature, maintain acid base balance, ionize calcium, platelet count target is more than 50 thousand, and PTINR less than 1.5. Okay, and fibrinogen 1 to 1.2 grams per liter is the target. Okay, so proper and prompt trial is the evidence for which the 1:1:1 ratio came into existence. Okay, so if they ask evidence for this, this is proper and prompt. You don't have to remember this. I just put this slide so that you understand what is this. Okay, it's categorized very easily. You can get this in multiple places. Okay, so what are the criteria for stopping? Hemodynamic stabilization, normalization of laboratory parameters, surgical control of bleeding has also occurred, and then you see that the patient does not have any risk of rebleeding based on interdisciplinary discussions. Okay, so when all of this is there, you can stop the MTP. So what are the complications associated with massive transfusion protocol? It can be TRALI, TACO, which is circulatory issues because of products, dyselectrolytemia, hypothermia, coagulopathy, dilutional thrombocytopenia, metabolic acidosis, infections, ABO input compatibility, and ARDS. Okay, so these are the issues with MTP. Okay, so whenever they ask you about hemorrhagic shock or MTP, first tell what is MTP, what is massive transfusion. They are different. Okay, after that, tell when you will activate MTP. Okay, after that, what do you do in MTP? All the 7 steps. Then what do you target in MTP? And if that particular target is not reached, what are the targets you need to reach? Your hemoglobin target of more than 7, your platelet of more than 50, your ionized calcium of more than 1 millimoles per liter. Okay, along with this, arresting the primary cause, the address has to be done to that as well. If there's an ongoing bleeder, surgical control if necessary, all of that has to be taken place. Okay, all of this you have to mention, and after stabilization of all these things, you have to tell that we can stop MTP, and later on you talk about complications. Then you talk about adjuncts in MTP, that is your tranexamic acid, write the evidence. Then you talk about what is the rationale of using 1:1:1 in MTP. Then you can write the evidence based on a proper and prompt trial. Okay, so this is how you answer a question about massive transfusion protocol. Okay, thank you.